So hello everyone, Dr. Nasir here. Hope your exam went well. Let's discuss microbiology questions from INI-CET November 2025. So let's begin with the first question. Sir, first we discuss bacterial infectious diseases. Okay, first question, sir. A 60-year-old man presents with an acute onset of syncope, cough, fever, and shortness of breath. This clearly indicates that patient is suffering from lung infection, that is pneumonia. Sir, whenever we see shortness of breath, that is breathing difficulty, or respiratory distress or dyspnea, that goes in favor of lung infection, usually pneumonia. Temperature 101 degrees Celsius, pulse rate 110. On auscultation, lung bronchial breath sounds are heard. See, bronchial breath sounds are heard means airless lung. Airless lung means alveolar filled with fluid, means consolidation. So it is telling there is consolidation, means typical pneumonia. See, first you have to understand how to approach the question, what examiner is trying to tell. With shortness of breath, examiner is telling there is infection in the lung. And with bronchial breath sounds, examiner is telling that alveolar filled with fluids, that is consolidation, goes in favor of typical pneumonia, lobar pneumonia. Sputum smear with gram stain showed in the image. So this is the sputum smear gram stain picture, that is what they're telling. And if you see the gram stain picture, sir, gram stain picture shows gram positive cocci in pairs, right? You can clearly see, sir, gram positive cocci in pairs are seen everywhere, right? Gram positive cocci in pairs. And once you see pneumonia, typical pneumonia, gram positive cocci in pairs, it goes in favor of pneumococcus. That is nothing but Streptococcus pneumoniae, pneumococcus. So clear-cut examiner is telling us, identify that this is typical pneumonia caused by pneumococcus, and pneumococcus is the most common cause of typical pneumonia. The organism found shows alpha hemolysis. Examiner is now telling, at least now please identify this is pneumococcus. Gram stain picture is given. Then examiner is telling alpha hemolysis on blood agar. Culture picture is given. Clinical picture is given. Clinical picture is telling typical pneumonia, and most common cause of typical pneumonia is pneumococcus. Microscopy show gram positive cocci in pairs, that says pneumococcus, right? Alpha hemolysis and blood agar, that says pneumococcus. At least now identify pneumococcus and give me the correct statement. That is what examiner is asking. Now examiner is on your foot. Identify it is pneumococcus. Now, if you see the revision videos ka class notes, see, so beautiful. You correlate with the examiner. Examiner says shortness of breath, pneumonia, and we have discussed here, right, that pneumococcus is the most common cause of pneumonia, manifest with dyspnea. Okay, that is there in the revision notes. It is not there in this part, but it is there written that it causes pneumonia, manifest with dyspnea. And next, if you see gram positive cocci in pairs, microscopy, sir, clear cut we have written gram positive cocci in pairs in microscopy. Again, if you see alpha hemolysis on blood agar, sir, we have written alpha hemolysis on blood agar. Clear cut exactly the way it is there, the same way it has come. After that, further if you continue, we have written pneumococcus is optochin sensitive, bile soluble, inulin fermenter. Again, if you see the options, they say bile soluble. Sir, you got the true statement, correct statement, directly exactly point to point from revision videos class notes, right? Point to point, the same way. Clinical picture, then microscopy picture, and then culture picture is in the question, and option where they're asking the biochemical test, bile solubility, is it catalase positive, false, it is catalase negative. That is also in revision was notes ka class notes, that streptococcus, pneumococcus, enterococcus are catalase negative. That is also there in general microbiology. Vancomycin is a drug of choice, false, vancomycin is not a drug of choice. So again, we have written here, if you see, amoxicillin or ceftriaxone is a drug of choice. Again, that is also there in class notes. No vaccine is present for the organism. Pneumococcus, we have vaccine, so it is a false statement. So beautifully, we have got the answer completely from the class notes. First question. Moving on to the second question. Which of the following is correct regarding acute rheumatic fever? Again, acute rheumatic fever we have discussed in class notes in cardiovascular system. And we have clear-cut written it is a non-suppurative complication of group A streptococcal pharyngitis. Group A streptococcus causes pharyngitis, followed by which a complication will occur that is known as acute rheumatic fever. So here it says it happens 2 weeks after group B streptococcus infection. False statement, because just now we have seen it occurs after group A streptococcal infections. Again, if you further see our class notes, we have written it causes pancarditis. It causes pancarditis, and it causes polyarthritis. It causes pancarditis and polyarthritis, two important key manifestations. And they say here myocarditis occur but not endocarditis. False statement. It causes pancarditis, pericarditis, myocarditis, and also endocarditis. And nowhere we hear that it causes valvular rupture. False statement. Ash cough bodies are seen. That is the characteristic feature of acute rheumatic fever. When it gets converted into rheumatic heart disease, ash cough bodies are seen, right, in the myocardium. The true statement is ash cough bodies are seen. One more question was there on acute rheumatic fever that can also be answered from class notes. Jones criteria have several major and minor criteria. So examiner is asking about the Jones criteria, major and minor criteria. Which of the following are included in major and minor criteria? Carditis included or not? Just now we have seen, see, we have written here, these are the major criteria and these are the minor criteria. So major may be a pancarditis and polyarthritis. Pancarditis and polyarthritis. Sir, pancarditis included. Polyarthralgia not included. Why? Once again, if you see, we have written polyarthritis in the major criteria, whereas polyarthralgia, that is pain, is in the inflammation in major, pain in the minor. So polyarthralgia is a minor criteria. Okay, they are told major or minor, so we have to include polyarthralgia also. Right? We have to include polyarthralgia. It is a minor criteria. And then if you see next are Sydenham's chorea, subcutaneous nodules, and erythema marginatum. Sydenham's chorea, right? Sydenham's chorea, sir, Sydenham's chorea is included. Subcutaneous nodules, erythema marginatum. Sir, erythema nodosum is not included. It is erythema marginatum. Means red color nodules are not included. Erythema nodosum means red color nodules, but erythema marginatum means a rash whose margins are red. So erythema marginatum, it is not nodosum. Shortened PR interval. If you see here, prolonged PR interval is a minor criteria. So shortened PR interval is not a criteria. Sir, carditis and Sydenham's chorea, we have two major criteria. Polyarthralgia, we have one minor criteria. So 1, 3 and 5 are included in major and minor criteria. If I see the option 1, 3 and 5, it is there in the C. So C is the right answer here. See again directly from the class notes, right? Sir, first question, pneumococcus, you have answered from respiratory system. Second question, right, and third question from acute rheumatic fever, you have answered from cardiovascular system. Moving on to the next one, an organism has pathogenesis shown below. Sir, what is the pathogenesis? Again, if you see the pathogenesis here, the clear-cut mentions inactivates elongation factor 2. Examiner's favorite mechanism, inactivation of elongation factor 2. It's keep repeating every time. And we have written in the notes that inhibits elongation factor 2 by two toxins, diphtheria toxin and Pseudomonas exotoxin A. There are two organisms, two toxins that inhibit elongation factor 2, diphtheria toxin and Pseudomonas exotoxin A. Which of the following is incorrect about the toxin? They're talking about incorrect about the toxin. So now here you see it is an exotoxin. It is a exotoxin. Sir, first you need to know that if it is Corynebacterium diphtheriae, it is exotoxin because it is gram positive. If it is Pseudomonas, it is endotoxin because it is gram negative. Sir, basic knowledge, gram positive produces exotoxin, gram negative produces endotoxin. Sir, so far here they have not told whether it is, right, Pseudomonas, or Corynebacterium diphtheria. But once you read the question, they say it causes myocarditis. Again, so though it is not here, because this question we have taken from the actions of toxin, but when you see the actual diphtheria, what we have mentioned in revision class notes, we have clear-cut mentioned diphtheria, the major, one of the important complication is myocarditis. So true statement, diphtheria causes myocarditis. It is a exotoxin. It is a Phage-coated toxin. Remember, we have three important Phage-coated toxin. Sir, CDE, Phage-coated toxins, cholera toxin, diphtheria toxin, and enterohemorrhagic E. coli virocytotoxin. So now by seeing the options, we know they are talking about diphtheria. It is an exotoxin and it causes myocarditis and it is coded by Phage. But obviously it is the most potent toxin known to man. No sir, false. It is not the most potent toxin known to man. Whether you take Pseudomonas toxin or even diphtheria toxin, that is not the most potent toxin what we know, which is toxic to man. So the most potent toxin, you can say it is botulinum toxin, which is more toxic to man. So false statement, whatever you consider, whether Pseudomonas or diphtheria, sir, the toxin is not most toxic to man. But if you see other options that goes in favor of diphtheria and remaining three options are true for diphtheria toxin, the false statement is myocarditis. The false statement means it is the most potent toxin to man. Sir, moving on to the next question. A scientist in a laboratory are working on making clones of SCFV gene of antibody by combining it with COVID-19 surface M3 protein. After several rounds of screening, they clone the gene. What is the expression of this gene on M3 protein known as? So this is completely a bouncer and complicated question. Right, this is not actually purely from microbiology, it goes with biochemistry from the chapter genetics, but still have considered this question. Right, let's discuss the topic phage display. So, phage means bacteriophage. What do you mean by bacteriophage? Bacteriophage are the viruses that infect the bacteria. Bacteriophage are not bacteria. Bacteriophage are the viruses that infect the bacteria. So now we take this bacteriophage. Which bacteriophage we take? M3. See here, preferred phage is M13. M13 bacteriophage is taken, and preferred gene are encoding antibody fragments like SCFV. We take the genes that are encoding for antibody fragments, SCFV antibody fragments. We insert these genes into M13 phage. Take the genes coding for antibody fragments, insert it into M13 phage. Right. Now what happens? When insert into M13 phage, phage produces antibodies and displays on its surface, because you have injected the gene producing antibodies. Now this bacteriophage produces antibodies, displays on its surface. Now selection of these antibodies after several rounds of screening, right? After several rounds of screening, we select the antibody. Why to select the antibody? That you can understand now. So this entire process is known as phage display, because we are inserting the gene inside the phage, and phage produces the antibody and displays it on its surface. That's why the process is known as phage display. It is a method to screen the proteins like antibodies to select the ones that bind best to the target. So though it is the question from purely from genetics, from biochemistry, but this mechanism usually used in pharmacology to produce monoclonal antibodies. To produce monoclonal method to screen the proteins like antibodies to select the ones that bind best to the target. Right, phage display, because the see here, M13 is a bacteriophage where you insert the genes which produces antibodies, and phage produces antibodies and displays on its surface. Then we have to screen and select the antibody, the best one that binds to the target. This procedure is known as phage display. So here, that is what they are talking about, right? SCFE gene antibody fragments are produced on M13 phage. The process is phage display, and this is done to select the antibodies which can bind best to the target, like monoclonal antibodies. Right, completely a bouncer, most difficult question from microbiology, right, which is purely from genetics, from biochemistry, and used in pharmacology. Right, a three pre and para integrated question, subjects integrated question. Sir, which of the following is an obligate intracellular bacteria? Sir, we have Ehrlichia, we have Tropheima vipelli, we have Stenotrophomonas maltophilia, we have Calmitobacterium granulomatis. Sir, which of them is obligate? See, obligate means what? Strictly intracellular. First of all, we need to know we have obligate intracellular, we have facultative intracellular. Obligate intracellular means they're strictly intracellular, they multiply only inside the cells. Facultative intracellular, though they multiply intracellularly, but they can also multiply extracellularly. That's why facultative intracellular. Facultative intracellular can multiply both intracellularly and extracellularly, but prefer intracellularly. That's why we call them as facultative intracellular, but obligate is strictly intracellular. See, usually obligate intracellular, so if you see the revision notes we have written, intracellular bacteria like Rickettsia, Mycobacteria, Neisseria, Chlamydia, and see here, these two are there, no, Rickettsia and Chlamydia. These two are obligate intracellular. Sir, among the bacteria, we have only two bacteria which are obligate intracellular, Rickettsia and Chlamydia. Though we have not specified it in the notes, I'm just specifying it now. Rickettsia and Chlamydia, these are the only two obligate intracellular bacteria we have. But when you take the Rickettsia, sir, Rickettsia is a big family having many brothers. We have discussed. Sir, one of the brothers of Rickettsia is Orientia. Orientia. Sir, Orientia is also obligate intracellular. Another brother is Coxiella. Coxiella is also obligate intracellular. Another brother is Ehrlichia. Ehrlichia is also obligate intracellular. Right? Except there is one more brother, Bartonella. Right? This is not obligate intracellular. So remember, we have 5 brothers of Rickettsia. So how many brothers? 5 brothers. Which are those? Rickettsia and Orientia, Coxiella and Ehrlichia and Bartonella. Sir, Bartonella is exceptional. Why? Sir, Bartonella is facultative intracellular. Facultative intracellular, and Bartonella is cultivable. Bartonella is cultivable, and that's how Bartonella differs from other brothers. Other brothers are obligate intracellular and they are non-cultivable. Okay, sir, with this, if you see, we have understood Ehrlichia is a obligate intracellular. So here the answer is Ehrlichia sheffiensis, which is obligate intracellular. Right. Moving on to the next question, sir. A laboratory is working with Mycobacterium tuberculosis culture. Which of the biosafety levels is required to handle these organisms? Mycobacterium tuberculosis. If you see our class notes, sir, in our class notes we have mentioned that category bioterrorism agents and biosafety levels. Sir, category A bioterrorism agents are anthrax, botulism, plague. Right. These are bacteria for which you require biosafety level 3. And smallpox, Ebola, Marburg, these are the viruses for which you require biosafety level 4. So you forget about category B, less commonly used. You directly move on to category C, bioterrorism agents. Category C, bioterrorism agents like Nipah, H1N1, coronavirus, and Mycobacterium tuberculosis, we use biosafety level 3, where we can see that category, right, Mycobacterium tuberculosis clearly comes under biosafety level 3. Exactly picture of class notes. Sir, Mycobacterium tuberculosis goes under biosafety level 3. So these are the questions what we have seen from bacterial infectious diseases. Sir, moving on to the viral infectious diseases. Sir, first they have asked a life cycle of a virus shown below. Which is the life cycle? Sir, in the life cycle, if you see clear cut, you can see what? Bats. Bats are there. Sir, when bats are there, we can say it is nothing but Nipah. Everybody could have identified, I know everybody have identified that this is the life cycle of Nipah. Once you see the bat, that is enough. And we have written fruit bat causing encephalitis, Nipah virus, and we have written 40 to 70% mortality. See in West Bengal and Kerala, right? See in West Bengal and Kerala. Here they say it causes encephalitis. Yes, we have discussed it under encephalitis. Okay, see here, parasitic encephalitis. This is viral encephalitis topic. Okay, that is just missing here, but it is there in the class. It is viral encephalitis topic. See, it causes encephalitis. True statement, right? Transmitted by fruit bat. Yes, it is transmitted by fruit bat. That's why it is Nipah virus. Nipah virus. And you mentioned 40 to 70% mortality. So 100% mortality is false statement. You know, 100% mortality is only one virus, that is rabies virus. There is no other organism which is having 100% mortality. False. Human are the major reservoir. False. Just now we say fruit bats are the major reservoir. It's a DNA virus. False. It is a RNA virus. We know it causes encephalitis. Even if you don't know other options, once you see the bats, you know it is Nipah. You know Nipah causes encephalitis. Such a simple question, man. From class notes you can answerable, because in class notes we have written Nipah causes encephalitis. And also mortality, 40 to 70, it's not rabies for 100% mortality. Right? You can answer it from the class notes. Sir, moving on to the next question, sir. A 40-year-old man with a known HIV infection. Okay, known HIV infection presents with cough and fever lasting for 3 months. Sir, HIV patient got cough and fever lasting for 3 months, got lung infection, opportunistic infection. The patient is diagnosed to have miliary tuberculosis, and they have given the opportunistic infection is miliary tuberculosis. A HIV patient is having an opportunistic infection, miliary tuberculosis. What is the next best step in the management? Right? You won't believe. This is also there in this revision notes. Right, sir? They're talking about iris, immune reconstitution, inflammatory syndrome. Right, here I told you, if a patient is having HIV infection, HIV with an opportunistic infection, same condition in the question. If ART started first, exaggerated immune response will occur, which leads to our tissue damage. That is what is immune reconstitution inflammatory syndrome, if ART started first. So what to do? I have written here, to prevent iris, start with treating opportunistic infection. First treat opportunistic infection and then HIV. See, such so beautifully concised and in an understandable way we have written here in the revision notes. Okay, first treat the opportunistic infection, then treat the ART. If you start ART first, you will get iris. So here, start ART, I will rule out. Start ART, I will rule out. I left with two options. Start ATT and 2 weeks later start with ART. Start ATT and 2 weeks later start ART. Though both the options are same. The one difference is, first A option is without corticosteroids, D option is with corticosteroids. Which one to opt here? For that, you see the disease miliary tuberculosis. Sir, miliary tuberculosis is severe form of tuberculosis with high bacterial load. Because of that, iris chances are more and TB meningitis chances are more To prevent TB meningitis, to prevent iris, not only we have to start ATT first, we have to add corticosteroids. I've given you the reason why we have to add corticosteroids. Miliary TB is severe form of TB with high bacillary load, high quantity of Mycobacterium tuberculosis. So when you treat, chances of spreading it to meninges causing tubercular meningitis, and chances of iris is also more, and that's why corticosteroids bring down the chances of iris and also the TB meningitis. To prevent these complications, we have to add, always remember, when you treat miliary TB, you have to add corticosteroids with anti-tubercular drug. And because he is a HIV patient, first you have to treat TB and then you have to start. 2 weeks later, we have to start ERT. An increased dose of dolutegravir, that is pharmacology based question, you know, right? Because anti-tubercular treatment include rifampicin, and rifampicin is an inducer of dolutegravir. That's why you have to double the dose. Right? Simple question, sir. Answerable from, though it is pharmacology based but integrated with microbiology, and we have discussed this. Iris, it is a very important complication of ART when you start ART first in a patient of HIV who is suffering from opportunistic infection. So next question, sir. Which of the following viruses most commonly causes diarrhea in adults? Again, if you see the class notes, we have discussed. Sir, viruses causing diarrhea: rotavirus, adenovirus, noro and saptovirus, astrovirus, raka viruses. Most common is Rio. And we have written rotavirus causes especially in less than 2 years of age. So rotavirus is the most common cause of diarrhea overall, but it usually causes in children. When you come to adults, it is the norovirus that is the most common cause of gastroenteritis in adults. That's why norovirus. Otherwise, all of them, they cause gastroenteritis. In children, most common is rotavirus. In adults, most common is norovirus. Next question, sir. Healthcare worker had needle stick injury. Healthcare worker had needle stick injury while handling a chronic hepatitis B patient. She has taken 2 complete schedules, 6 doses. She has taken 2 complete schedules. See, 1 complete schedule consists of 3 doses. 1 schedule of 3 doses, another schedule of 3 doses of HBV vaccination already taken. She was tested and was diagnosed as a non-responder. Non-responder means even after taking 2 complete schedules, non-responder means her antibody titer is less than 10 milli-international units per ml, means she is not attained a protective antibiotic. She has not attained a protective antibody titer. Right? What is the most appropriate management in this case? See here. So 3 doses of hepatitis, 3 or more than 3 doses of hepatitis B vaccine taken. If antibody titer is more than 10, then nothing to take, because you have a protective antibody titer that will protect you. But on exposure, if antibody titer is less than 10, so you don't have protection. What to do? Repeat again the 3 doses. If you have taken earlier 3 or more doses, again repeat 3 doses, not 1 dose, 3 doses. Right? 3 doses. Second time you have to repeat 3 doses, not 1. Again, if exposure occurs after some time, again if the antibody titer is less than 10, sir, here 3 doses taken and here 3 doses taken. Sir, 2 times you have to take 3 doses. Even after that, if antibody titer is less than 10, we call that person as a non-responder, and don't repeat the vaccines, non-responder, and don't repeat the vaccines again in this patient. So 3 doses ka 1 series, after that 3 doses ka another series. If antibody titer is less, even after that, if it is less, non-responder, you call it as non-responder. And now whenever further exposures, patient have to take only 2 doses of immunoglobulins 1 month apart. Simple, right? Now here you non-responder, 2 doses taken to give 2 doses of HBIG now, and 4 weeks later means 1 month later. Right? Simple question. So next question, sir. A pathogenesis of virus is shown below. Which of the following statement is correct about the virus? So if you see this, right, sir, stratum corneum, stratum granulosum, stratum spinosum, you know, this is the skin. And if you see here, the virus is there, capsid virus particles replicating viral RNA, viral DNA. If you see clearly, they have written in the image papillomavirus. A papillomavirus, human papillomavirus. Is it a RNA virus? No, man, it is a DNA virus. False statement. Clear cut, it is there in the blueprint of virology that it is a DNA virus, right? DNA non-enveloped viruses, PAP, papoadeno and parvo, papillomavirus. It is a oncovirus. True statement. Here, human papillomavirus causes what? It causes what? See here, we have written human papillomavirus causes anogenital warts, and it causes cervical cancer. And we have a subunit vaccine containing L1 antigen to prevent the cancer, to prevent the human papillomavirus infection. Sir, it is a oncovirus. Yes, true statement. It causes cervical cancer. Most common presentation is painful genital lesion. False. Warts are not painful. Vaccine against virus is not available. False. Vaccine is available. So we got the true statement. It is a oncovirus. Again, simple question. We can answer from human papillomavirus. Most commonly repeated human papillomavirus. Examiner's favorite. Sir, next question. A 30-year-old man presents with pain, redness, photophobia, like you see in the image. Sir, there is a pain, redness, and photophobia. He has a history of contact lens usage. Eye examination shown below. Sir, what do you see in the eye? Sir, I see a ring infiltrate. What do I see? I see a ring infiltrate in the cornea. Ring infiltrate in the cornea. And he was a contact lens user. Right. So we came to the diagnosis contact lens keratitis. You know, the most common cause of contact lens keratitis is Pseudomonas. Pseudomonas. Right. And you know, Acanthamoeba parasite can also cause contact lens keratitis. Now we have to decide whether it is Pseudomonas or Acanthamoeba. Most common is Pseudomonas. If it is Pseudomonas, they are asking which stain is used. I will go with the gram stain. If it is Pseudomonas, I will go with the gram stain because it is a bacteria. But sir, ring infiltrate goes in favor of Acanthamoeba. Pseudomonas, you see hypopion. Right. Right. Question integrated with ophthalmology. Right. Pseudomonas manifest with hypopion. Acanthamoeba manifest with ring infiltrate. The image is telling. See the ring infiltrate in the cornea. Right. It is caused by Acanthamoeba. So Acanthamoeba means we won't use gram stain. And it is not acid fast. It is not acid fast. And gomerymethamine is used in case of fungi, not parasites. Chalcofluoride. Remember, chalcofluoride is used for fungi. It is used for fungi and also for the cysts of parasites. And also for the cysts of parasites. Acanthamoeba being a parasite, it is having trophozoite and cyst. And chalcofluoride is used to stain fungi and also the cysts of parasites. Acanthamoeba being a parasite, the cyst of the Acanthamoeba can be stained with chalcofluoride. Other options are not suitable for Acanthamoeba. If it would have been a Pseudomonas, I would have gone with gram stain because it is a bacteria. Ring infiltrate telling it is Acanthamoeba. Hope you have understood. So next question. Filarial nematode show periodicity. We know that it shows periodicity. No, it is seen during the night. See here. Sir, filariasis we have discussed. Microfilaria larva. Right. At night, we have to take the blood and we have to prepare the peripheral blood smear because they enter into the blood during the night. We have written this. But what they are asking is, when not in peripheral circulation, when they are not in the blood, when they are not in the blood, Uchere bancroft is seen in the capillaries of which of the following organs? Such actually, for me, though it looks a stupid question because when they are not in the blood, where are they present? Why do we need to know? Right? Because when they are there in the blood, we collect the blood and we identify them. We see them, we identify them. But when they are not there in the blood, where are they present? Actually, there is no need to know. But they have asked, so your answer is lung. Remember, when they are not there in the peripheral blood, usually they are in the lymphatics and lymph nodes, and from there they travel and go to the lung capillaries. And usually, the important site during the daytime, especially, usually they are found in the lung capillaries. So this is a complete bouncer question, difficult to answer. Right? Nobody could have discussed this, and nobody will discuss this, and nobody could have predicted in their dreams also. And these kind of questions are like bouncers. Sometimes examiners, they simply ask whatever they feel like to ask. Otherwise, I don't think this question, right, it is not making any sense according to me, because during the daytime or when they're not in the blood, where they are present, we are least bothered about where they are present, because we know when they have to, we need to know when they come in the blood peripheral circulation night, so that I can take the blood, I can identify them. I'm not going to take lung biopsy or capillary blood vessels. I'm not going to take from there to identify them. Right. Anyways, sir, during the daytime, when they're not in the peripheral blood smear, they are present in the lung. Nighttime, blood, daytime, lung. You just remember this. Sir, moving on to the next question. Sir, 27-year-old man presents with hemoptysis. Given below are clues for this diagnosis. What is the treatment of choice? Sir, hemoptysis means, sputum with blood. So lung is affected. So here they have given the lung. Lung is affected. Here there is a crab. Okay, crab, something related to crab. And what do I see? Egg. What is this egg? And see here, this is the operculum. Operculated egg. Operculated egg. A lung, operculated egg. Paragonimus westermani. And a Paragonimus westermani hosts are snail and crab. Snail and crab. And Paragonus westermani is a trematode. Is a trematode. And what is a trematode? Sir, most of the trematodes treatment is praziquantel. Praziquantel. From class notes. You won't believe. See here. Sir, parasitic atypical pneumonia. Paragonimus westermani. Paragonimus westermani. Right, see here, operculated egg with the thickening opposite side of the egg. You can see here, operculum on one side, thickening on the other side. Thickening on the other side. And you can see here, treatment is praziquantel. Treatment is praziquantel. Right. So directly from class notes, Paragonimus westermani, treatment is praziquantel. So next question. The egg or ovo shown below belongs to which organism? Again, directly from class notes. See the egg here. So these are blastomeres inside the embryo. Right. When you see blastomeres inside the embryo, ankylostoma duodenale or Necator americanus, both are hookworms. Sir, here also you can see blastomeres inside the embryo. Blastomeres inside the embryo. Ankylostoma or Necator? Ankylostoma is not there, Necator. See here, we have mentioned both ankylostoma and Necator. Right, ankylostoma and Necator. Both are hookworms. This is the egg of hookworm. Blastomeres inside the embryo is the characteristic feature. Again, directly from class notes. We have all the eggs discussed. Next question. On PS examination, right, these findings is seen. What is the diagnosis? Right, what is the diagnosis? Sir, if you see this is cervix with bleeding spots. Sir, cervix with bleeding spots, strawberry cervix, you know, this is the characteristic feature of Trichomonas vaginalis, Trichomoniasis, right, discussed in class notes. Trichomonas, right, and we know strawberry cervix is the characteristic feature of Trichomonas vaginalis. So next question. Match the following presentation with most common causative organisms. Cutaneous larva migrans, visceral larva migrans, larva occurrence, Cercarial dermatitis. Again, directly from class notes. See here, we have mentioned larva migrans topic. And see, cutaneous larva migrans most commonly caused by Ankylostoma brasiliensis. Visceral larva migrans most commonly caused by Toxorhocanis. These two questions are there. These two things we have discussed in the notes. Right. Sir, cutaneous, Ankylostoma brasiliensis, visceral, Toxochora canis. See here, cutaneous. One goes with Ankylostoma brasiliensis A. One goes with A. See here, 1A, 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 1A. I will rule out A and D. So B and C. B and C, 1A. Two possibilities. Visceral larva migrans. Visceral larva migrans. Right. Toxochora canis. Toxochora canis. Go with 2 and D. Sir, 2 and D. I got the option C. 2 and D. Right. 2 goes with D. Then if you take the 3, larva occurrence is strongyloides. 3 goes with B. Sir, here 3 goes with B. Everything will fall into its place. Cercarial dermatitis goes with cystosoma. Sir, cercarial dermatitis 4. Cystosoma 4 goes with E. Sir, option C is the right answer. See, larva occurrence. Larva occurrence is nothing but fast larva migrans. Fast larva migrans is slow. Fast larva migrans is larva occurrence that you see in with strongyloid. Strongyloid is show fast larva migrans. That is nothing but larva occurrence. Cercarial dermatitis known as swimmer's itch. That is cystosoma. You know, cystosoma usually, right, we get acquired from the infection of larva. Larva is the infective form. Larva is present in water. Cystosoma larva is present in water. And from there it enters by skin penetration. Larva enters by skin penetration. Once it enters by skin penetration, it causes an allergic reaction that is known as cercarial dermatitis, also known as swimmer's itch. Even if you don't know all these things, sir, by knowing these 2 points, which are important points, which are there in the revision notes, Ankylostoma brasiliensis is the most common as cutaneous, Toxochora canis is the most common cause of visceral, you can answer the question, right? So next question. Which of the following infections does not happen due to thorn prick? You know, dermatophytes infection, you get it from the environment, or from the anthropophilic, zoophilic, or from the animals, pet dogs and pet cats. Whereas chromoblastomyces, sporotrichosis, mycetoma, all of them they acquire from thorn prick injury. So next question. A 35-year-old man presents with slow growing swelling on the right foot with occasional discharge of black granules. You know, this swelling on the foot with black color granules, you know, disease is mycetoma, and you know, black color granules goes in favor of Madurella mycetomatis. Again, you see, you won't believe, see, Madurella mycetoma, Madurella mycetomatis, black color discharging granules. Most common repeated directly from class notes. Black color granules goes with Madurella. Nocardia, Actinomadura, whitish yellow, light yellow. Chromoblastomycosis, no granules. Nocardia, Actinomadura, that cause bacterial mycetoma. Madurella causes fungal mycetoma. It is fungal mycetoma because black color granules goes in favor of Madurella. Next question. For differentiation of Candida species, the organism is incubated at 37 for 3 hours. After 3 hours, findings shown in the identify the Candida species. Sir, what is this? This is germ tube. Germ tube is produced by albicans and dublinensis. Here, dublinensis is not there. So, albicans directly from class notes. See here, same picture, same image. Germ tube. And we have written here, albican species most common, followed by dublinensis species. Germ tube is produced only by 2 species, albicans and dublinensis. So, dublinensis is not there. So, albicans directly from class notes. Next question. A 27-year-old man present with fever, shortness of breath. Fever, shortness of breath. A fungating mass is seen in the right lung. A fungating mass is seen in the right lung. Histopathology of on modified Gorocoats silver methamine is shown below. Identify the organism. Right, directly from class notes. Again, see the image. Right, sir, fungi with acute angle and dichotomous branching. Aspergillus. Fungi with acute angle dichotomous branching. Aspergillus. Right, and it is a septate mold. Right, see here, clear cut written, septate mold, septate hyphae with acute angle and dichotomous branching. Aspergillus. Sir, acute angled branching, septate hyphae, Aspergillus is right answer. When you see the image, that is enough to say, right sir, it is acute angle and dichotomous branching. Acute angle and dichotomous branching, septate mold, Aspergillus. Such a simple direct question from class notes, so many times repeated. So next question. A male patient present with fever and knuckle rigidity, neck rigidity, meningitis. CSF analysis reveals low sugar, elevated RBC, cryptococcal antigen positive. Okay, cryptococcal meningitis. Which of the following is used in the initial treatment of the condition? See here, sir, Cryptococcus plus class notes. See the treatment. Liposomal amphotericin B plus flucytosine for first 2 weeks and fluconazole for next 8 weeks. Fluconazole for next 8 weeks. Therefore, amphotericin B plus flucytosine. First question. First, amphotericin B plus fluconazole, liposomal amphotericin plus itraconazole. No. It is one only. It is one only. Right. Initial treatment, initial management is amphotericin B plus flucytosine, not fluconazole. Fluconazole is later, we have to not add. Actually, after 2 weeks, we have to stop liposomal amphotericin B and flucytosine, and you have to start fluconazole as maintenance for 8 weeks. Then also, it is based on, right, the condition is opportunistic or not. If condition is opportunistic, HIV, we have to continue fluconazole till CD4 count crosses 100. Otherwise, initial treatment is liposomes. And again, sir, from revision notes. Sir, with that, we have discussed all the questions from microbiology, and hope you enjoyed the session. Hope you got the proper answers. Totally, if you see microbiology with right integrated sources, approximately we have got some 23 to 24 questions. There was one more question. They said PCR, steps of PCR. Steps are PCR. Right. What are the steps of PCR? Sir, denaturation, annealing, and extension. That was also right appeared in the exam, and that is also there in revision notes. If you include that, it will become somewhere around 24 questions. Out of 24 questions, sir, 18 are there from revision class notes. Right, that goes somewhere around more than 75% strike rate from revision notes. Sir, we have seen more than 75% strike rate in this INI-CET. Right, INI-CET November. Whereas we have seen more than 85% of strike rate in May, November from just the revision notes. And we have seen approximately around 90% strike rate in the NEET PG 2025. So this is the strike rate from our revision notes 2025. We have the recall videos, and hope you found beneficial the revision videos of microbiology at Marrow, and I have seen the feedback of yours, and thank you. It was a next level feedback. All right, and really I'm happy that you liked and loved the revision videos of microbiology at Marrow. Right, we'll come up with more interesting further, and hope my lectures and my videos are beneficial. With that, guys, prepare well. All the best. Those who have got the good rank, from my heartfelt congratulations to you all. And those who have not got the good rank, don't be sad. Right, consider it as an opportunity, so that at least now I will put my maximum efforts. I will prepare in a proper way. I will prepare for the upcoming May INI-CET, and also have a chance to give in the NEET exam. So all the best for your preparation. Thank you.